Hello, guys. This is Miss Merle once again, and we will be talking about toxicology. Let's start first with defining toxicology. This is the scientific study of the adverse effects of chemicals, substances, or situations on living organisms and the environment. And it encompasses a wide range of topics, including the mechanisms of action, the nature of poisons, and the effects of various substances on health. With this, in this presentation, we will tackle toxins and toxicants, exposure routes, commonly through inhalation, dermal contact, ingestion, and also about the very essential thing on dose response relationship, wherein the dose makes the poison. That's fundamental in toxicology, and the mechanisms of toxicity. And we will also be talking about areas of focus, so clinical, environmental, and forensic toxicology. Toxicology is the study of poisons with four major disciplines. So we have mechanistic, descriptive, forensic, and we have the clinical toxicology. So for this one, guys, with mechanistic, it's more the focus is on the cellular and biochemical effects of toxins, and it's really it augments or it helps in the design of therapy and exposure tests, while descriptive toxicology is more on the utilization of animal experimentation so that we will be able to predict harm levels in humans, and this is known as risk assessments. And regulatory toxicologists interpret data to establish safety standards based on descriptive toxicology. And when it comes to, on the other hand, when it comes to medical legal consequences of toxin exposure and methods, then that's the time we will use forensic toxicology. And for the last one, this one examines interrelationships between toxin exposure and diseases with emphasis on diagnostic testing and therapeutic interventions. People, we are exposed to toxins through most common 50%, half of the cases through intentional poisoning. So it's very sad, a very sad thing. Suicide attempts. We also have, of course, things that we are not really intentional in doing. So accidental exposure, 30% of cases, and it's very commonly seen in kids or children because kids are innocent and they don't know what they're eating or playing with. And then for in the adult setting, we have the occupational exposure, common in the workplace, industrial, or specifically in the agricultural settings. So the routes of exposure, guys, we also have most common is we have ingestion. So most common in the clinical setting, and we should not forget also that accidental inhalation and transdermal absorption can also happen. So absorption of toxins. So the absorption really needs the toxins need entry into the circulation primarily through the GIT, and toxins the absorption happens through passive diffusion. And hydrophobic substances are, of course, hydrophobic, water based. They are easily absorbed as compared to non-hydrophobic substances or lipid soluble substances. And ionized substances cannot diffuse passively but may be absorbed based on the pH. So it has to be those substances must appear as weak acids for them to be absorbed in the stomach and weak bases for them to be absorbed in the intestines. And we also have factors influencing absorption, so the dissolution rate, gastrointestinal motility, and interaction with other substances. The dose response relationship. So first, what is a poison? So it is anything or any substance that can lead to harmful effects upon exposure. With always remember the fundamental law in toxicology is that the dose will always be a key factor in toxicity. The dose will always make the poison. Toxicity index. This one correlates those with harmful responses, often using lethal outcomes as a measure. Well, toxic effects. Most toxins cause harmful effects at lower doses than death. This can be assessed through responses like elevated serum ALT or GGT, and the liver is the organ that is commonly affected. We also have the cumulative frequency. So this one, it's a tool to evaluate various toxic responses across doses. So showing how the population reacts differently to the dose. And then we have the TD50, LD50, and the ED50, and the TI, or the therapeutic index. TD50 stands for toxic dose 50, lethal dose, LD50 for the lethal dose 50, and ED50 for the effective dose 50. So the dose predicted to cause toxic response in half of the population toxic. So you can see signs and symptoms. That's TD50. But the dose that is used to predict and can cause death, or there's mortality, so 50% in 50% of the population, that's lethal dose 50. While for ED, we're looking for how effective the dose is. So that's more on therapeutic effects. So that's the dose predicted to have therapeutic effects in 50% of the population. So toxicity is distinct from the lethal dose. So this one, toxic, it's more on morbidity. So there's we can observe the presence of illnesses and signs and symptoms, but this one, the patient was already like dead. There's death already in LD50. How about the TI? This is the ratio of the TD50 to ED50. So if it's high, if the index is large, so meaning it implies that the toxicant is with a few side effects with and is within its effective dose 50 or its therapeutic range. So it's better for medication, for example, to have a large TI or therapeutic index. So this is the dose response relationship. So the first curve represents the therapeutic effect, followed by toxic, and lastly, of course, the lethal effect. This is the ED50, TD50, and the LD50. So half of the population, showing effectiveness of the dose, half of the population showing signs and symptoms of a particular toxicant, and half of the population that have died after ingesting, inhaling, or having an absorption of the toxicant. So acute and chronic toxicity. Acute, of course, acute means short term, and always, most often, it involves high dose exposure causing immediate toxic effects. While chronic toxicity, guys, this one, it is caused by repeated. So there's repetition, and the dose is lower. But this one happens through time, for a long period of time, and potentially leading to, there is always with chronic toxicity the word, remember the word accumulation or delayed effects. Accumulation or delayed effects. So analysis of toxic agents, we have two manner of testing. So we have the screening and the confirmatory form of testing. So for the screening test, usually, of course, this will involve simple and often usually qualitative in nature. We're not measuring the concentration, but we are just trying to see the absence or presence of a particular toxin, poison, or toxic. In but even if the screening tests are simple, but their sensitivities are high. However, their specificities are low, and they're used to detect specific substances or toxin classes. But this one, if you really wanted to confirm, especially if it's a medical legal case, then a more specific, and this is the secondary method that is really used to ascertain and confirm the presence of the toxicant or toxins. So, what are the common analytical methods implied or used in toxicology? The most common, we have the immunoassays for screening drugs, often detecting drug classes or specific drugs like your tetrahydrocannabinol, your THC in marijuana or Mary Jane. We also have the thin layer chromatography, simple and expensive for organic substances, and the GC for both. For this one is very useful. In GC is very useful in qualitative and quantitative analysis of volatile substances, and often combined with mass spectrometry. We also have the toxicology of specific agents. So let's start with alcohol. So I'm just wondering why some people have alcohol, because knowing that the general toxic effects of almost all alcohols will always be seen as depression that can lead to confusion, euphoria, unconsciousness. And whenever you are drunk, your inhibitions are lost. So somehow you are no longer coherent and you are disoriented. And the mechanism of alcohol toxicity is that, again, it depresses the CNS by altering membrane properties. However, the recovery from CNS effects is fast after what you will cease drinking alcohol. Specific toxicities: alcohol is metabolized to aldehydes and acids with distinct toxicities from each type of alcohol. So this one, guys, alcohol. So first is ethanol, your ethyl alcohol or your grade alcohol. So according to research studies, excessive consumption of alcohol will always result, or had already, of course, resulted to social, economic, and health issues. So the cost is over $100 billion yearly, and it contributes to about 20% of hospital admissions, and is a leading cause of premature death, about 80,000 deaths annually in the U.S. Consumption during pregnancy can cause fetal alcohol syndrome, so it's not really a good idea to drink alcohol if a female is pregnant. And then, guys, chronic effects: long long-term ethanol use, 50 grams per day for 10 years. So if you're doing this, there is a damage to the hepatocytes, leading to fatty liver, and then eventually it will end up to liver cirrhosis, wherein the liver tissue is already scarred and unfunctional. And the metabolic byproduct of alcohol is acetaldehyde. So this is the end product formed during ethanol metabolism, and is a key factor in ethanol's pathologic effects. So, largely why we can observe these chronic effects, we can attribute these effects to the presence of acetaldehyde. And then next, alcohol is methanol, wood spirit, or methyl alcohol. Common in solvents and homemade alcohol. In Germany, they make their own alcohol. And then this one can lead to acidosis and optic neuropathy. This is the only alcohol that can really lead to blindness. And then, in contrast to ethanol or ethyl alcohol, the metabolic byproduct of this alcohol is formaldehyde, it's formalin, formic acid. Now let's shift to the isopropyl alcohol. So, well, the effects are similar to ethanol; they're just the same. However, the metabolic byproduct acetone, it has a longer half life, hence the symptoms are longer. And then the much celebrated antifreeze agent in the U.S., the ethylene glycol. So this one is found in antifreeze and hydraulic fluids used in cars. And commonly, kids are affected, ingested often by children because it has this characteristic sweet taste, and it causes metabolic acidosis, kidney damage, and the hallmark when it comes to the renal pathology. It will give us telltale signs of calcium oxalate crystal formation. So Cox crystals are seen massive formation of Cox crystals. We can really see them in massive formations in ethylene glycol or antifreeze poisoning. Again, kids are more affected, and the urine picture will give us the urine laboratory results will show us Cox crystal formation or Cox, presence of Cox, Kox or Cox. And then determination of alcohols, specimen types. Of course, the good thing, it's very versatile. We can utilize plasma, serum, and whole blood for ethanol determination. But always remember, since we're talking about alcohols and they are volatile in nature, there is this fast evaporation. So the sample should be sealed to prevent ethanol evaporation. Next is determination of alcohols. So what are the methods? We have osmometry. That's why we have osmolality. Serum osmolarity or osmolality, useful for screening but not specific for ethanol. And then we also have gas chromatography, GC. This is the reference method for ethanol determination because it can detect other alcohols like methanol and isopropanol. So if you think of alcohol and the reference method, the gold standard, always think of GC or gas chromatography. However, we can also utilize enzymatic methods like enzymatic methods utilizing alcohol, ADH, alcohol dehydrogenase, to oxidize ethanol to acetaldehyde, which can be monitored by the reduction of NAD to NADH. So method sensitivity, the enzymatic methods, they are relatively specific for ethanol but may produce low results for methanol or isopropanol intoxication. And if we are talking about alcohol determination in the clinical lab, there's always this very important thing you should not forget when it comes to legalities, the chain of custody. So this one, from the sample collection until to the releasing of results, there should be proper documentation and handling. This, these things are really critical for legal ethanol testing, especially in cases like driving under the influence of alcohol. Driving under the influence of alcohol in the US. So carbon monoxide. So now we have carbon monoxide or CO, and this one is the only toxicant that you cannot see it, you cannot smell it, you cannot hear it because it's colorless, odorless, and tasteless. And the bad thing, it's easily, rapidly absorbed into the circulation. And sources include the incomplete combustion of carbon-containing substances, and from gasoline exhausts, from the gasoline engines, and improperly ventilated furnaces. So it's not a good idea to leave your car left running in at a very closed garage. We also portable generators should also be placed outside and not inside because of carbon monoxide poisoning. And if our there is corrosion or disconnected water heater or vent pipes, kerosene or gas heaters can also produce carbon monoxide. Improperly installed kitchen range or vents on gas or wood burning fireplace can also give you CO poisoning, carbon monoxide. So the mechanism of toxicity. So the thing with carbon monoxide, it has this very high affinity. It binds to hemoglobin up to 200 to 200 times strongly as compared to oxygen. So, in the presence of both, we have oxygen and CO. CO surely will bind readily to hemoglobin, displacing oxygen. So, there's no longer oxygen attached to the hemoglobin. So a small amount of carbon monoxide can lead to even a small amount there is like 0.1% in the air. So 50% carboxyhemoglobinemia. Hence, there's a reduction in the oxygen carrying capacity of the blood. So decreased oxygenation, we know what happens. There is a change in the oxygen hemoglobin dissociation curve, and the curve tends to go leftwards. And if it's going to the left, meaning there's reduction in oxygen delivery to the tissues, so the patient will succumb to hypoxia, so especially affecting high oxygen demand. So organs like brain and the heart are really affected with your readily affected, easily affected by your CO poisoning. See the leftward shift. So increased affinity for O2 because there's a reduction in O2 already. That's the hallmark for your carbon monoxide poisoning. So the trend is it tends to go leftward rather than to the right side of the curve. So hypoxia, what do you mean by that? Decreased oxygen delivery to the tissues, and it causes, of course, a significant harm to what organs? Again, to brain and the heart. So treatment, 100% O2 therapy is the primary treatment, and in severe cases, if we can still save the patient, there is this hyperbaric oxygen therapy. Guys, remember the half-life of your carboxyhemoglobin is 60 to 90 minutes on 100% oxygen with normal respiratory function. So that's the thing. Please also be familiar with this table because it's very informative when it comes to the levels of carboxyhemoglobinemia and the symptoms associated with it. So next is the spot test. So for CO, we will be performing a spot test wherein the presence of carboxyhemoglobin, it gives the blood a cherry red appearance. And then the spot test involves adding uh, sodium hydroxide to whole blood. And also the persistence of a pink solution suggests carboxyhemoglobin levels is more than 20%. So that's a very bad thing. So spectrophotometry, it measures the absorbance at multiple wavelengths to calculate the concentration of carboxyhemoglobin and other hemoglobin forms. And usually this is done in automated systems. Next, caustic agents. So exposure risks of caustic agents, we have aspiration, ingestion, and let's start with the aspiration. So it leads to pulmonary edema and shock, and of course, it can lead to death. Ingestion. So what will happen if caustic agents are ingested? So lesions in the esophagus and GAT, so leading to tears or perforations. The patient can also manifest the vomiting of blood. The vomitus is blood tinge, or there is hematemesis, abnormal pain, and shock. So, sources of caustic agents commonly found in the household products and occupational settings. And for the treatment, always clinicians resort to dilution as a corrective therapy. Next is cyanide. So, cyanide, for the diagnosis, this one requires rapid evaluation, typically using ion specific electrode methods or photometric analysis with microdiffusion separation. Chronic low level exposure can be monitored by measuring urinary thiocyanate levels. And then symptoms, low level, and we have high doses. So the symptoms vary. At first, if the exposure is just low level, then you'll just feel headaches, there's respiratory depression and dizziness. However, if cyanide is really high, the dose of it is really high, it can lead to seizures, coma, and death. So this one, you should, as the clinician, you should be very rapid when it comes to the diagnosis. And we can use ion-specific electrodes, ISE methods, or we can have photometric analysis with microdiffusion separation. Chronic low-level exposure can be monitored by using or measuring, not using, rather, urinary thiocyanate levels. Next in line is arsenic. So this one is we can observe it in the natural and man-made substances. So it's in the air, agriculture, and common in smelting industries, industrial, and commonly used in suicide cases. So absorption, rapidly absorbed via passive diffusion, and then they are cleared via renal filtration in the free ionized state. So what's important with the arsenic is always remember this toxicant binds to thiol groups in proteins. Once there's binding, the structure and function of proteins will be disrupted. And another disadvantage is the long half-life because it is slowly cleared in the body. Hence, there is this possible accumulation with chronic exposure. So for low level exposure, symptoms will manifest or show as GIT, distress, anorexia, and fever. However, a high level exposure will always lead to neurological damage like peripheral and central edema, renal effects, hematopoietic effects, vascular disease, and sadly death. Analysis include AAS or atomic absorption spectrophotometry and is commonly used for arsenic analysis. We also have blood and urine are used for short-term exposure, and if you wanted to assess out from the patient, if the patient is having a long-term exposure, we can utilize the hair and the fingernail samples. Cadmium. So another toxic and so sources. Industrial processes, especially electroplating and galvanizing. So it's common in paints, pigments, plastics, and nickel cadmium batteries. So sometimes, especially I've seen this type of poisoning in kids who are able to swallow batteries specifically nickel cadmium batteries. So the early sign of toxicity, renal dysfunction, and then it will point out to tubular proteinuria, glucosuria, and amino aciduria. How about the mechanism of toxicity? Still binds to proteins and other cellular components. So once they will bind proteins, protein function will be hindered, and the most readily affected organ with cadmium toxicity is, or it will talk about the kidneys. So, analysis excessive exposure is typically evaluated by measuring blood or urinary cadmium content using AAS or atomic absorption spectrophotometry. And exposure is mainly via inhalation in industry and ingestion of contaminated products. Next one is lead. So, sources. Well, lead is really ubiquitous. It's a common environmental contaminant found in old household paints, common in the US, in gasoline. That's why, have you noticed we have the unleaded gasoline right now, which is more eco friendly? And automobile exhaust residues, lead pipes, and various industrial processes. And foods may also contain lead, though the average intake of adults is it should not be beyond what is the normal. And then absorption, ingestion is the primary route of exposure. So ingestion through the mouth. So adults absorb 5 to 15% of ingested lead, while so the kids are more affected. They are readily affected. They are still having the bone development is still ongoing as compared to adults. So the lead binds to macromolecules and distributes throughout the body. And the largest pool of lead is seen in the bones and in the soft tissues. So if you are looking for the presence of lead and might wonder where these toxicants have accumulated, think of the bones, the skeletal system, and include also the soft tissues. So, how is lead eliminated out from the body? So, lead is primarily eliminated by renal filtration. But since most of it is stored in the bones and in the soft tissue, so we can really expect a very slow elimination rate over time. And the bad thing, the absorption happens cumulatively over time. So, toxicity, first, of course, neurological. So it can cause encephalopathy, edema, swelling of the brain, and ischemia. So at high levels, lead can lead to convulsions, coma, and stupor. However, low levels may like very subclinical effects, behavioral changes in the kid, hyperactivity like ADHD, and reduced IQ. Like you might wonder why is the kid very like not very but is not really functioning. The mental capacity is not so good as compared to the kid's peers. So it could be that the kid have swallowed when the kid was still a baby or a toddler crawling and then eating the lead paints at home. So that can be one of the causes. So hematologic toxicity will manifest as it there is inhibition in heme synthesis. So the kid is having a low IQ, the kid is anemic, and the kid is having ADHD that is really or those things as a whole will point out to lead toxicity. And elevated levels of ALA or aminolevulinic acid and protoporphyrin are indicators, and zinc protoporphyrin fluorescence is used for testing. So lead renal. So in the renal system, there is tubular dysfunction with glycosuria, amino aciduria, and hyperphosphaturia. However, later it can lead to fibrosis. If alcohol can lead to cirrhosis, lead can lead to fibrosis in the renal system, especially kidneys. Other effects lead to hypertension, the birth defects, and the kid is having a compromised immunity or low immunity. So, what's the most reliable method for us to assess or evaluate the toxicity of lead? We have graphite furnace at AAS. This is the most common. But actually, guys, this lecture is intended on the US setting and not in the Philippine setting, okay? Because we don't have much of the atomic absorption spectrophotometry being utilized in our labs here in the Philippines. Next, urinary testing can also assess recent exposure, and special care is needed during specimen collection to avoid contamination. So, treatment, we have DMSA to remove lead from the body, and these agents form complexes with lead that can be excreted via kidneys. So, forming complexes meaning they are chelators. They will catch or they will form a chelate with lead, form a complex with lead, so that lead, instead of staying in the body, can be excreted via the kidneys. And monitoring the urinary concentration of lead helps to assess the effectiveness of treatment. The other one, guys, is mercury. So mercury has a lot of forms, right? And the thing we should know is elemental mercury is the one which is liquid at room temperature, low vapor pressure, and hence, if it has a low vapor pressure, it is not readily absorbed if we're able to ingest it. So, inhalation of elemental mercury vapor is unlikely to cause significant effects. Elemental mercury. But inorganic mercury, it can lead to localized toxicity in the GIT, and this one is partially absorbed. This one is not easily absorbed. This one is partially absorbed. This one is highly toxic because it is readily absorbed. Your organic mercury, your methyl mercury. So the routes of exposure for mercury, we have inhalation, commonly as an accidental exposure in the industrial setting, especially with the inorganic and organic forms. We have the inorganic and organic. And remember, these things are toxic, moderately toxic, and highly toxic. Ingestion is the most common route, especially if, like, some people love to eat fish, especially salmon. But salmon also contains mercury and tuna. And next is dermal absorption can also occur but is not as common as inhalation or ingestion. But the two routes commonly associated with mercurial exposure is R, sorry, inhalation and ingestion. So absorption and distribution. You might wonder why elemental mercury is not readily or easily absorbed because it has this low vapor pressure and it exists in as a viscous liquid, while inorganic mercury is partially absorbed, affecting the GIT, and organic mercury is rapidly and efficiently absorbed through passive diffusion, and it tends to concentrate in the brain and peripheral nerves. Organic mercury. So, how is it eliminated? Through renal filtration of free or low molecular weight mercury species. However, because mercury often binds to proteins, its elimination is slow, leading to cumulative effects with chronic exposure. So, the toxic effects of the forms of mercury, general mechanisms, again, similar to other toxicants, binding to proteins, disrupting their function and structure. Hence, and remember, proteins are essential in enzyme enzymatic activities. So and it inhibits enzymes and leads to damage to the tissues. So elemental mercury causes GIT disturbances, and there is this, yeah, necrosis and death, while inorganic mercury affects multiple organs, kidneys, causing glomerular proteinuria and renal tubular dysfunction. But while organic mercury, if this one is in the GIT, this one's in the renal system, the organic mercury will really lead to very toxic effects to the nervous system, causing mumbling speech, loss of balance, and low exposure, even at at low exposure levels. Higher exposure levels can lead to hyporeflexia, hypotension, bradycardia, and renal dysfunction. So mercury diagnosis, guys, we can have the whole blood as the sample, or a 24-hour urine collect- collection. So what's the methodology? Using AAS, atomic absorption, or ASV, or anodic stripping voltammetry. Special techniques are required for elemental mercury analysis. So the what are the key points? Chronic exposure with mercury, it will always lead to a cumulative effect, particularly affecting the kidneys and the nervous system. Mercury toxicity is serious, especially for neurological and renal health, and chronic exposure can have long lasting effects. So, now, guys, let's go outside. No, just kidding. We will be talking about, let's go to the fields, agricultural setting, pesticides. So, pesticides, these are chemicals designed to kill or harm unwanted organisms such as pests and insects. But these substances can also cause harm to humans if ingested or inhaled or swallowed accidentally. They are commonly used in agriculture, vector control, and to combat urban pests. However, while they serve beneficial purposes, pesticides can pose significant health risks. See, when there is accidental or occupational exposure. Sorry. So the routes of exposure, we have food contamination, inhalation, ingestion, and intentional. So primary route is food contamination. So it's really important for us to wash our veggies and fruits properly, because we can be exposed to pesticides. And a good way to know if sorry guys, if your veggie or fruit is with pesticides or not, if we can observe those worms, meaning pesticides are not there because those worms were able to thrive. But if the fruit or veggie seems flawless and perfect, then there's a great possibility that during the planting and harvesting, pesticides were utilized. Next, we have inhalation and dermal absorption in occupational settings, industrial settings, ingestion hand to mouth, kids, and then intentional, yeah, this especially with suicide attempts in farmers, guys. So we have categories. We have the insecticides, herbicides, and organophosphates. So for if we wanted to control insects, we have insecticides. Control weeds, grasses, we have herbicides, and organophosphates. Uh, Organophosphate poisoning is common in the agricultural setting. Commonly associated with pesticide poisoning. So mechanisms of toxicity for organophosphates and carbamates. So we have the acetylcholinesterase inhibition. So we have organophosphates or carbamates. They block acetylcholinesterase. And what is acetylcholinesterase? This is an enzyme that is needed for acetylcholine to be broken down. And then acetylcholine is a neurotransmitter in both insects and mammals. And we have, what's the role of acetylcholine? So it is involved in nerve transmission and muscle stimulation, and the enzyme acetylcholinesterase terminates its action. So what's the effect? The prolonged presence of acetylcholine at nerve receptors causes overstimulation, leading to toxic effects in the body. So the symptoms of exposure of pesticides, we have salivation, lacrimation, and involuntary urination and defecation. Low level, even at low level exposure. So the kind of poisoning with this one is very ugly. There's salivation, drooling, tearing, and then there's involuntary defecation and urination. Oh my god! But with a moderate exposure, it leads to a very slow heart rate, twitching of the muscles, slurred speech, and behavioral changes. But in severe forms of exposure, respiratory failure is imminent. We cannot avoid it, leading to death. So, diagnosis of organophosphate poisoning, we have the inhibition of acetylcholinesterase is a sensitive indicator of exposure because always remember that acetylcholinesterase is membrane bound. Its activity is typically measured in RBCs because RBCs have a higher surface activity. We also have serum pseudocholinesterase. So this enzyme is inhibited by organophosphates, but we should remember that it is less specific and sensitive in detecting organophosphate poisoning. So what are the challenges in acetylcholinesterase testing in serum pseudocholinesterase testing? Decreases in SCHE can also be seen in conditions such as acute infection. So, hence, this one is not so it's not so specific because we can also observe this in other disease states. So we should not rely much on serum pseudocholinesterase. It's really best to use acetylcholinesterase inhibition. So the normal serum pseudocholinesterase range is between 4,000 to 12,000 UL, with symptoms of toxicity appearing when there's about 40% reduction in activity. And erythrocyte ACHE, or acetylcholinesterase inhibition, is the preferred test for confirming organophosphate poisoning, especially in cases of suspected exposure. So for the therapy, we have the immediate and we can also have the confirmation or confirmatory. So in immediate cases, suspected cases of organophosphate poisoning, antidotal treatment can be started based on decreased SCHE activity, while for the confirmation, further testing for RBC ACHE activity should be done to confirm poisoning. So now, guys, we're bound to go to the toxicology of the drugs of abuse. So, what's the medical importance of drug abuse testing? For us to see substances in overdose situations for appropriate treatment and so that we can have the reasons are rationale for treatment of addiction in non-overdose cases, and drug abuse testing is commonly done by screening urine samples. So the most common sample for drug abuse testing is urine. And then screening detects recent drug use but may miss patients with short-term abstinency. So that's the problem if the patient is intelligent because he will abstain and then it will lead to false negative results. And also, next, guys, drug testing in the various contexts. So, tests must be legally admissible, accurate, precise, and secure. Protocols prevent specimen adulteration and ensure proper specimen handling because, similar to alcohol testing, guys, alcohol determination, which must always be associated with the chain of custody. Drug testing, of course, is the number one testing that requires the chain of custody, in which even starting from the sample collection up to the releasing of the results, it is witness. There is a witness so that we are sure that the specimen is not adulterated and there is no intentional, how do you call that? There is no intentional contamination of the results done by the patient side. So testing methods, the two-tiered approach, screening and confirmatory. We can also have common analytical procedures, but these things are not common in the Philippine setting, but only in the US setting. So let's have the two-tiered approach with the screening and confirmatory. So screening tests, simple, rapid, and always inexpensive. So it's based on detection of drugs on their chemical homologies. And then for the confirmatory testing, these tests rather use highly sensitive and specific methods like GC, so similar to the common analytical procedures. So specific drugs with high abuse potential, amphetamines or amphetamines. We have methamphetamines, meth, ice, glass, or chalk. So this one is used for narcolepsy and ADHD. It used to be a normal a drug, not a drug of abuse, but a drug for therapy. They have a high, but it is correlated with a high abuse potential. So once it's abused, it will result to mental and physical capacity, restlessness, and irritability because you can experience these things knowing that amphetamines are potent CNS stimulants. So they are dopamine and norepinephrine releasing agents and reuptake inhibitors. Chronic use results to tolerance, psychological dependence, and overdose. So you might wonder why your patient is having hypertension and arrhythmias, even if the patient is eating healthy. And screening for amphetamines involves urine analysis and confirmation via liquid or gas chromatography. So let's go to MDMA, ecstasy or Molly, or methylene dioxymethamphetamine. So this is a derivative of amphetamines, and it can give you hallucinations, the euphoric rush, and increased sensitivity because it's both a stimulant and a psychedelic drug. So you can see things not there, and then you are highly stimulated. So this is an empathogen entactogen drug of abuse. You tend to severely empathize with others if you are abusing this. Adverse effects include seizures, hyperthermia, cardiac and liver toxicity. So this one requires GCMS mass spectral due to typical screening limitations. Let's go to the steroids common in athletes. Synthetic compounds related to testosterone, and for this is highly abused so that this state of having an increased muscle mass and athletic performance can be achieved. So naturally, anabolic steroids mimic the male sex hormones, testosterone, and again, physical and psychological effects. But prolonged use and abuse leads to heart issues. There's cardio enlargement of the heart muscle. There's a the testes will atrophy, and there is possible sterility. So, detection challenges exist for newer steroid forms. We have That's why now people are using the testosterone to epi testosterone ratio for screening. Next, cannabinoids. These compounds are psychoactive and seen or they are present in marijuana, causing euphoria and memory impairment. And commonly, if the person is abusing this, we can observe the bloodshot eyes. So the delta 9 tetrahydrocannabinol is lipophilic. So it loves the adipose tissues. There's accumulation in the adipose tissues. Hence, if they are present in the adipose tissue, so the elimination is surely slow, and hence there is prolonged detection in urine. And guys, urine tests detect the metabolite THCCOH for 3 to 5 days post-use or up to 4 weeks in chronic users. Cannabis refers to the dried leaves, cannabis, flowers and stems and seeds of the cannabis plant. So confirmation via GCMS is sensitive and specific with concentration standards to differentiate passive versus direct inhalation. So cocaine, coca, coke, crack, crank, flake, rock, snow, or soda or cut. So these things will refer to the local anesthetic. Actually, cocaine is used normally as in nasal surgeries. It's an anesthetic, guys, with few adverse effects at therapeutic doses. However, if you will abuse this, it will give you this intense euphoria producing stimulation. And this one offers a strong addictive potential. So this cocaine comes from the leaves of the coca bush, Erythrocylum coca. Actually, Coca-Cola before, guys, used to have cocaine. That's why the name of the soft drink is Coca-Cola or Coke. But when they have realized that cocaine is not good, that's why people during the early stages of Coca-Cola in the market, they were somehow addicted to it. But now, after knowing that it can have this strong addictive potential, it's already removed from the Coca-Cola we are drinking right now. And then at high concentrations, it's a potent CNS stimulant causing euphoria and excitement. And then common forms of administration, we have insufflation, IV, smoking. That's why if it's being smoked in its free base form, that's known as crack. Half life. The good thing with cocaine, it remains in your body for only the half life is zero point 0.5 to 1 hour. And then acute toxicity, hypertension, seizures, MI. And then toxicity is related to dose and route. So IV, of course, will give you more higher forms of toxicity as compared to smoking. And then metabolism, rapid hepatic hydrolysis to inactive metabolites. The board exam question for cocaine is what is the primary metabolite? It's benzoyl ecgonine, and it can be detected in the urine up to how many days, guys? Here, after a single use, and some 20 days in heavy users. So it really remains in the body for a long time. And then testing, again, urine immunoassay. We can have immunoassays, but always, if you will be asked, drugs of abuse, they are the confirmatory testing will always be GCMS most often. Opiates. So this one. So from if opiates, think of morphine, codeine, and heroin and oxycodone. So they are extracted or refined from the natural plant matter, the poppy sap, from the poppy, opium poppy, and five. Actually, I was able to have opiates in Thailand because it's legal in Thailand. It's incorporated in their cough syrup, and then that time I was having a cough, so I was able to take or to feel what it feels like to have opiates. No, guys, I haven't abused it. I took it in therapeutic levels, not in levels that can be correlated to abuse. And then, what are the most common synthetic opiates? We have fentanyl, methadone, and meperidine. So, abuse potential high, leading to tolerance and psychological, physical dependence. Usually, acidosis, respiratory, but for alcohol, it's metabolic acidosis. This one, it leads to respiratory acidosis. So, what's the antidote? Overdose treatment, naloxone, opioid antagonist. Naloxone or some, the brand name is Narcan. And then, always remember, guys, GCMS for confirmation. So, we also have the angel dust, PCP or phencyclidine. So, this one is most drugs of abuse will give you this stimulant. This one is really contradicting. You'll be stimulated, but then you will feel depression, have anesthetic effects, absence of pain, and hallucinations. But it's really funny. See, stimulation and then depression. First, you'll be stimulated, and later you'll be depressed. I don't like this one. And it can lead to agitation, hostility, and paranoia. So somehow I don't like this one. See, hostility. And then what else? Similar to most of the drugs of abuse, they will distribute into the fat or adipose tissues and in the brain. So always remember, guys, if it readily accumulates or distributes into the adipose tissue, so always remember what happens to elimination. The elimination will be slow. And this one is even unchanged in the urine. It's treated and changed in the urine. And then chronic use, it's detectable 7 to 30 days after use. So PCP also remains in the body for a long time, like cocaine, 20 days in heavy users, while PCP or your angel dust, will be there with chronic use. It will be there within your body for a month. So now let's go to the sleeping pills, the tranquilizers, or the sedative hypnotics, sedatives or hypnotics. So CNS depressants, depress the CNS, use as tranquilizers or sedation. So if you can hear barbiturates and benzodiazepines, those are the things. Secobarbital, phenobarbital, diazepam, your Valium, lorazepam, Xanax. So abuse potential from high, the barbiturates are highly abused, while benzodiazepines, they are abused but in low levels. If you, this is the bad thing with this one, it can really lead to respiratory depression. So some teens in the US, they're brought to the ER and then they're no longer breathing. It's because of the abuse of sedative hypnotics. And then, especially if taken together with alcohol, potentiated, alcohol, ethanol accentuates the toxicity of sedative hypnotics. Because alcohols are also seen as depressants, right? So this is a synergistic effect together with ethanol plus sedative hypnotics. And then, yeah, testing immunoassays and then with liquid LC for confirmation. That's the end, guys. Thank you for listening and don't forget to study.